Chapter 22 here, abdominal emergencies. I'm going to cover the physiology and anatomy, abdominal pain or discomfort, conditions, and assessment and care of abdominal pain or discomfort. So the abdomen, there's many different organs in there, right? Many from several different body systems. A lot of different things can affect the abdomen and cause pain. Can cause confusion when determining the cause of abdominal emergencies in the first place. Throughout the patient assessment, you need to be extremely thorough and try to get to the root cause of the actual pain or discomfort. A specific diagnosis may not be necessary, but heading in the proper direction is good to do. You may not be able to know exactly, but have a general direction for treatment and care. So the abdomen, region between the diaphragm and the pelvis. Again, many organs, organ systems. You got the digestive system, the reproductive system, and the endocrine and the regulatory. So here's a little diagram. This is in your book to look closer at it. You got your solid organs, your spleen. Anytime that is lacerated, ruptured, they're going to bleed extremely heavily. The liver, the pancreas, and the kidneys. Typically, the spleen, liver, and kidneys are issues that you will run into. And there's going to be different symptoms that will kind of point you to that direction. Hollow organs, you have your stomach, gallbladder, the, really don't know how to even pronounce that one, the duodenum, large and small intestines, and the bladder. Now, with the solid and the hollow organs, that comes more into play to know the difference if it's solid or a hollow when it comes to trauma. And car accidents, depending on if it's a solid or a hollow organ, will kind of lead you in the direction of what may be injured, okay? Especially like the bladder, it's a hollow organ, okay? But if it is a full bladder, you have more of a chance for the bladder to be injured during a car accident, high level of suspicion there. All right, so the abdomen is divided into 4 quadrants. The right upper, lower upper, or left upper, I'm sorry, right lower, and left lower. Okay, when typing it out into your narratives, it needs to be written like this: the right upper quadrant, left upper, in that order, okay? The epigastric region, here's a diagram, the actual quadrants, where they're located. Again, it's on the patient, not you looking at the patient, okay? The umbilicus is another one that you need to know. That's where your belly button, okay, where the umbilical cord was. Now, that region is called umbilicus, and that's the straight line up and down there. Organs of the abdomen: peritoneum, the membrane lining the abdominal cavity and covering each organ. All right, it's attached to the abdominal wall. Visceral covers each organ. Most enclosed within this peritoneum, the parietal, a few lie in the extraperitoneal space. That's outside. That's the kidneys, pancreas, part of the aorta lie in this region. Bladder and part of the rectum lie inferior to peritoneum. Here's another diagram. Again, this is in your book if you want to have a closer look at it. Again, it's good to know where the organs are located, especially in the event of trauma or abdominal pain. You can kind of pinpoint what may be affected there. All right, so visceral pain originates from the organs within the abdomen. There's fewer nerve endings that allow for only diffuse sensations of pain. It's typically going to be dull or achy. It's not going to be sharp, okay? So if they're complaining of a dull abdominal pain, regardless of what they're rating it on the scale of 1 to 10, it's typically going to be from visceral pain. Colic, intermittent pain, may result from distension or contraction of hollow organs. Persistent or constant pain often originates from the solid organs. Peridial pain originates from the peridial peritoneum. Many nerve endings allow for specific efficient sensations of pain. These are going to be your sharp pains. It's often severe, constant, and localized to a specific area. A tearing pain, a common type of abdominal pain. It originates in the aorta. I don't really call it common, but if they have a tearing pain, especially in the upper quadrants, you need to think of a AAA, the aorta. Separation of layers of this large blood vessel caused by an aneurysm. Retroperitoneal location of aorta causes pain to be referred to the back. They're going to have that tearing sensation and pain in the back. Referred pain, perception of pain in skin or muscles at distant locations. Right, so the abdomen has many nerves from different parts of the nervous system. The pathways overlap as they return to the spinal cord. Pain sensation is transmitted from one system to another. This is especially true with gallbladder pain. A lot of times they're going to have pain in their shoulder, pain in their scapula. All right. So some conditions: appendicitis. It's the infection of the appendix. Signs and symptoms: nausea, sometimes vomiting. Pain often initially referred to umbilical region, followed by persistent right lower quadrant pain. That's where your appendix is located. Rupture of the appendix, sudden severe increase in pain, contents releasing into the abdomen, causes severe peritonitis. There's going to be a lot of pain with these. So anytime they have right lower quadrant pain, you want to ask if they still have their appendix. Peritonitis, irritation of the peritoneum, usually caused by foreign material in the space. It's very sensitive there, especially to acidic substances. A lot of the stuff that we eat and drink are acidic in nature, especially certain pops. Irritation causes involuntary contraction of the abdominal muscles, causes pain. So they're going to have pain. Their abdomen is going to be rigid. It's going to be kind of hard. Gallstones, inflammation of the gallbladder, often caused by blockage of its outlet by gallstones. Same thing as like kidney stones. There's a lot of videos on YouTube of them cutting open a gallbladder. You can look at the stones there. It's actually very interesting to see. Symptoms often worsen by ingestion of fatty foods. So they're going to have severe right upper quadrant pain or epigastric pain, and it's often referred to shoulder pain. Pancreatitis, inflammation of the pancreas, common in patients with chronic alcohol abuse. As we talked about in the previous chapter, it's going to affect their pancreas and their liver. Signs and symptoms: epigastric pain, often referred to back and or shoulder pain. Again, so those nerve endings cross over each other. You're going to get a lot of referred pain with different systems that are affected. GI bleed. It's a hemorrhage within the lumen of the GI tract. Can be minor, can be severe. Blood eventually will exit through the mouth or the rectum. If you ever smell a GI bleed, you will always remember that smell. If it's exiting through the mouth, you're going to have a brownish emesis, typically looking like coffee grounds. Through the rectum, it can be black tarry stools, unless it's a current bleed, in which you may see bright red blood. It's often painless. A lot of times people won't even know they had it. I personally had a GI bleed. It's been about 2 years ago. Ended up in Iowa City for it. Had no idea whatsoever. There was zero pain. Just wasn't feeling right just one night, and that's how I found out after I vomited. Gastric ulcers, it's holes in the GI system from highly acidic gastric juices. This can be from your pops, your Mountain Dew, your Coke, a lot of acid in those. Can cause severe pain and peritonitis. So the signs and symptoms: dark colored stool, maroon to black, it's often very tarry, smells god awful. Frank blood from the rectum, hemorrhoids, vomiting coffee ground appearing blood. So imagine taking, let's say Coke, because it's brown, and throwing in a bunch of coffee grounds. That's what it's going to look like. Or vomiting of frank blood. Pain can be absent, and it can also be severe. The triple A, abdominal aortic aneurysm. Ballooning or weakening of inner wall of the aorta. It will tear and separate from the outer layers, dissection. The weakened vessel bulges, as we've talked about before with aneurysms. It may continue to grow. It can eventually rupture. If this happens, they're going to bleed out very quickly. Abdomen will be distended. Progressive, often sharp or tearing abdominal pain. Again, it can go to the back, radiates to the back. Palpable abdominal mass, possibly pulsating. You can feel it when you're palpating the abdomen at times. Possible inequality in pedal pulses. So sudden severe increase in pain may indicate a rupture. High aortic pressure causes rapid internal bleeding. Typically, they're going to bleed out before you can ever get them to a hospital. Sudden progression of shock, they're going to be hypotensive, and likely exsanguination, fatal hemorrhage. So a hernia, you'll deal with these, you'll see these quite a bit. Typically, it's not a medical emergency. It's a hole in the muscle layer of the abdominal wall, allowing tissue or parts of organs, mostly the intestines, to protrude up against the skin. When they flex their abdomen, you can actually see it protrude through and stick out there. May be precipitated by heavy lifting. That's a good way to get a hernia. May cause strangulation of tissue or a bowel obstruction. The reason for that, when the intestines are not where they're supposed to be because of that tear, they can become twisted around itself or other organs, and then it can constrict that and cause death to whatever tissue is affected. May require surgical repair depending on how bad the hernia is. Sudden onset of abdominal pain, often following exertion, because of using the muscles the hernia is protruding through, and it causes a lot of pain. Palpable mass or lump on abdominal wall or crease of groin. I don't know if females, if they do it for them, but guys, you've been to the doctor, had to turn your head and cough, you're actually checking for a hernia there. Renal colic, severe flank pain caused by kidney stones traveling down the flow there. Signs and symptoms: severe cramping, intermittent pain in flank or back. Frequently referred to groin pain, nausea, and vomiting. So if a patient has lower flank pain in their back, it will typically increase with urination, be a sharp stabbing pain. And sometimes they can feel the pain from their back going around to their abdomen. Typically that's going to be kidney stones. Cardiac involvement. Pain from an MI may be felt as abdominal discomfort. Cover this in cardiac, especially with elderly females. They're going to describe it as epigastric pain, ingestion, or digestive discomfort. Some of them will kind of call it like a heartburn. Always consider the possibility of a cardiac emergency as a cause of abdominal symptoms. Remember, everything's cardiac, but proven otherwise. So, assessment and care of abdominal pain or discomfort. Since there's so many potential causes of abdominal pain, it's tough to pinpoint what the actual root cause may be. It's not your role to diagnose the root cause. I mean, you can just say they have abdominal pain and leave it at that. Focus your efforts, perform thorough secondary assessment, identify serious or life-threatening conditions as always. Protect yourself from blood-borne pathogens. Abdominal pain, you need to be aware there could be a GI bleed, may come in contact with blood. A lot of times they're nauseous, vomiting, so be aware of that. Be aware of the odors that may direct you towards a possible GI bleed. Determine if patient's condition is medical, trauma, or both. So with the primary assessment, you got your general impression. I don't know why they always put these out of order, but ABC's first, general impression. Note the level of consciousness. Consider application of O2. If they're hypoxic, titrate to effect. So get the history. As always, the onset. How long has this been going on? What were you doing? Etc. What makes it better or worse? Movement, position, anything like that. Quality, describe the sensation in your abdomen. Is it dull, etc. Have them point to the location. Don't ask them to tell you where it is. Have them point to it. Then ask them if it radiates. Does it go anywhere else? The pain. Where does it start? Where does it go? How bad is the pain? Scale of 1 to 10. Excuse me. Time. Do you have pain all the time? Is it intermittent? Has it changed? Has it gotten worse over time? Alright, so female patients. A lot of different things that you need to ask on this. I don't ask where are you in your menstrual cycle. I will ask, when was your last period? Is there any chance of being pregnant, etc.? Do you have any bleeding currently that is not menstrual bleeding? On top of that, you need to know about the flow of the bleeding, okay? Is it normal for you? How many pads are you going through, etc.? Have you had this pain before? And if so, what was the cause? Okay. Is it possible you are pregnant, and are you using birth control? Your sample history, allergies, medications, pertinent past history, last oral intake, events leading to the emergency. Geriatric note, decreased ability to perceive pain. Okay, geriatric is your elderly, right? As we talked about before, after 30, everything starts to decrease. Everything starts to not function as properly, including the nerves. So they don't perceive pain as well as somebody who was younger. They may have more serious causes of abdominal pain because of the everything decreasing in function. They have a lot of medical issues by this time, on a lot of medications. Can be a lot more serious causes. More likely to be life-threatening in the geriatrics. May be complicated by medications. Okay, they already don't perceive pain as well, and a lot of times they have chronic pain anyway, so they're on pain meds. If they're complaining of severe abdominal pain, it could have been dealing with it for quite a while, and you're dealing with something more serious. So you need to do a physical exam. You're looking for distension. Is the abdomen pushed out further than normal? Any discoloration? Is there any like bruising, etc.? Anything protruding? This would be your hernias sticking out on one side, or it could be a cancerous mass. Palpate the abdomen. You want to use your fingertips and save where the pain is for last. So you're going to palpate each quadrant. So if they have, say, right lower quadrant pain, that will be the last one you palpate. I would personally typically will do like the upper quadrants, one to the other, then I will do the lower. So when you're palpating, you're looking for rigidity. It's going to be hard, it's not going to be soft. You're looking for pain. And on top of that, you need to look ask the patient, is the pain when I press in or when I release? Okay. A lot of times with an appendix, you're going to have rebound pain, which is you can press on the right lower quadrant, but it's going to hurt the patient more when you let go. Okay, that's called rebound pain. You're going to look for guarding. This is the patient kind of tenses up and protects themselves upon palpation. Also look at the patient's face when palpating. Can be a giveaway on what's going on. Vital signs every 5 minutes. You're looking for pulse, respirations, blood pressure, pulse oxygen. You're checking all of that. If you feel that they're stable, every 15. So general abdominal distress. Some will result from digestive system disorders, can be cardiac, diabetic, food poisoning, flu. A lot of different causes for abdominal pain. Assess and care for these patients with the appropriate attention to the airway. This is especially important if they're vomiting. If they're nauseous, vomiting, protect the airway. Make sure it stays patent. Make sure it's open. Try to work with the patient to calm them down, reduce their anxiety. They're in a lot of pain. If you can keep them calm, it actually helps the patient dramatically. Never give the patient anything by mouth. You don't want them eating or drinking. Okay. Patient care. Get your ABCs. Maintain the airway. Be prepared to suction. O2 if need be. Titrate to effect. Put them in a position of comfort. Left lateral recumbent for airway protection if they're been vomiting, and transport to the appropriate facility. Again, with the position of comfort, some patients may want to lay down, have their knees up, whatever works best for the patient. So an 89-year-old female with a history of diabetes, hypertension, and gallstones is complaining of nausea and dizziness about 20 minutes after eating. What are the concerns with this patient? Okay. Is this an abdominal emergency, diabetic, cardiac? You have to determine that. Elderly patient, abdominal pain, you are going to think possibly cardiac, right? They can present with abdominal pain. It's cardiac until proven otherwise. And how will you know? It's difficult being a basic because you can't read a 12 lead and determine if it's cardiac. If you have a cardiac monitor, do a 12 lead. You can send it to the receiving hospital and ask them to read the 12 lead. What will your treatment be? They're nauseous. Are they vomiting? Position of comfort. O2 if need be. Not really a whole lot you can't do. You can't give pain meds. It's comfort care and transport to a hospital. Quick chapter review here. All complaints of abdominal pain or distress must be treated as serious emergencies requiring transport. There's so much going on in the abdomen, you just never know. A lot of times as a medic, I won't even give pain meds because I don't want to mask the symptoms. The only time I'll give pain meds is if I have a long transport. It's your responsibility to primarily to assess the patient and report your findings. You can't really diagnose in the field. Okay, it's extremely difficult. But again, like I said, you want to try to go in the right direction. Female, you're asking about periods, any possibility of pregnancies. Especially early pregnancy, it could be ectopic, right? That's going to cause some severe lower quadrant pain. And there are many more resources available than in the field. You get them to a hospital that can do a CT scan of the abdomen. Your assessment should include thorough patient history, physical exam, but you got to put your hands on the patient, and vital signs. Look for signs and symptoms that could signal serious trouble. Maybe that pulsating mass, right? That can tell you it's AAA, and that tearing pain radiates to the back. Coffee, ground emesis, black tarry stools, etc. Your care will consist of protecting the airway, give O2 if needed, put them in a position of comfort, and transport the patient. That's really about what you're going to do. Take all appropriate standard precautions. Again, there can be vomiting, there can be blood that you are exposed to. Take your precautions. Carefully clean and disinfect equipment and the ambulance, especially if they vomited or had diarrhea. Uh, at some point in your career, you are going to have diarrhea and vomit all over, possibly yourself, at least your stretcher, but quite a bit in the ambulance as well. Abdominal organs provide a variety of important functions to the body. A lot of different systems in there, a lot of different organs. The abdomen has 4 quadrants, with the midline and the umbilicus. Classifications of pain can help identify specific abdominal dysfunctions. Assessment and management always take a higher priority than determining the exact cause. It's too hard to be able to tell in pre-hospital setting. Knowledge of the characteristics of specific abdominal disorders can help you kind of go in the right direction. Again, there's not a whole lot you can do to treat, but the more information you can give the receiving hospital, the better. Care for a patient with abdominal pain should include treatment of immediate life threats, as always, O2 if needed, as always, and position of comfort. Alright, what are 5 signs and symptoms of abdominal distress? Describe the difference between visceral and peridial pain. You're going to need to know that for test purposes, but out on the street, not so much. What is the emergency care for a patient experiencing abdominal pain or distress? Cover that. Position of comfort, O2 if need be. Protect the airway and transport. The 4 abdominal quadrants, right upper, left upper, left lower, right lower. So, critical thinking. You were called to a patient with abdominal pain. He describes the pain as severe and says it has been on and off for the past several days, becoming severe within the last hour. What additional questions would you ask the patient? Okay, anytime that you have abdominal pain, one of the main ones, any nausea, vomiting, any recent trauma, okay, any diarrhea, you're going to ask about their bowel movements, etc. They've been eating, drinking, okay. Just by simply being dehydrated can cause abdominal pain. You're going to ask different questions if they're female. You know, when was your last period? Any chance you could be pregnant, etc. And what position would he likely most be comfortable? It varies from patient to patient, honestly. There's no right or wrong answer for this one.